session. As we know now, we will have two very important experts in the field, Professor Fabricio da Silva Costa and Dr. Conrado Coutinho. They are both authors of the recently published guideline on the ISUOG guideline on the role of ultrasound on the prediction of a spontaneous preterm birth. So we will start with Professor Fabricio da Silva. He is the acting director of the Maternal Fetal Medicine Unit at Gold Coast University Hospital and professor of obstetrics and gynecology at Griffith University, Gold Coast, Queensland, Australia. He has done a lot of valuable research on prenatal diagnosis, preeclampsia, IUGR, preterm birth, and among other subjects. He's now the chair of the ISUOG Scientific Committee. He's part of the ISUOG editorial board, and Fabricio will be presenting the first part of the ISUOG practice guidelines, as I said before, on the role of ultrasound in the prediction of spontaneous preterm birth. So Fabricio, the platform is yours, and thank you very much.
Thanks so much for the kind introduction, Catalina. Thank you, Kypros, Leona, ISUOG, and the Fetal Medicine Foundation for the invitation. Congratulations for this amazing event. It's so nice to contact with over 6,000 colleagues from all around the world. Just let me talk about the first part of our guideline that was published in July last year. I'm going to present about screening and prevention of preterm birth in asymptomatic women without previous history, and this will be complemented by my colleague and first author of the guideline, Conrado Coutinho. This is the team of the guideline that I really like to thank you for this fantastic work, and I think that this is a quite important guideline to guide practice around the world. I'm sure that all you know that preterm birth is a huge public health issue. We have over 15 million preterm births worldwide, and with delivery before 37 weeks. And of course, it's more remarkable when delivery happens before 34 weeks and with more complications in extreme prematurity before 28 weeks. This is extremely associated with neonatal death. You have around 1 million deaths per year, and a significant disability, and of course, related with the gestational age of delivery. Preterm birth is not just a complication for the neonates, but because some of them, they are related with placental dysfunction, is also a risk factor for maternal future development of cardiovascular morbidity and mortality, and of course, long-term impacts for the child and the adult that was born prematurely. Unfortunately, the rate of preterm birth globally is on the rising. It's increasing. Doesn't matter our best efforts to try to avoid it, but certainly some things that I'm going to show you is going to help us to try to minimize this big issue. The global rate of preterm birth is variable, but is around 11%. In Australia, for example, is around 8%, but I'm originally from Brazil, and the rate of preterm birth in Brazil, for example, is 12%. There's a huge regional variation on that, as you can see in this WHO publication, with most of the low and middle income countries having high rates. And not surprisingly, because unfortunately the US has a huge issue in terms of public health. US is a high income country that also the rate of preterm birth is very high. We know that there are some maternal factors that they are high risk for preterm birth. Previous history of preterm birth is the highest risk factor. However, around 40% of the population, they are on their first pregnancy, and you cannot use that as a surrogate. We have other risk factors. If a patient has a very high risk factor for preterm birth, if possible, this woman has to go early on during the pregnancy for a preterm birth clinic. If this is not available for a maternal fetal medicine unit, or for a high-risk obstetric unit. When you check pregnancy factors, multiple pregnancy is another important risk factor, but the factors that we can evaluate by ultrasound, certainly cervical shortening is the most important one, and this is the way that you can screen a general population at the same time of the mid-pregnancy morphology scan. We know that we are using worldwide a cutoff for cervical length in mid-pregnancy between 18 weeks to 24 of 25 millimeters. As short as the cervix is, highest is the risk of preterm birth. And this is true in singletons, and of course, this is also true in twin pregnancies. But when you are detecting someone with a short cervix, what you can do to avoid preterm birth, especially preterm birth before 34 weeks, is using progesterone as a medication as first choice, and in some cases when there's no a clear diagnosis of cervical insufficiency, you can use cerclage as a second line of treatment. Who are the professionals able to do that? And of course, the ideal scenario that someone that was trained and was certified. The Fetal Medicine Foundation has a course and certification for cervical assessment in mid-pregnancy. As the Americans, they have the CLEAR, that's the Cervical Length Education Review. There are two programs that you can be trained and you can be accredited to access properly the cervical length in mid-pregnancy. Who are the patients that we have to measure the cervix? Basically, it's everybody. If someone is low risk without previous history, everybody that comes for the morphology scan between 18 to 24 weeks. The ideal way to measure the cervix is via vaginal ultrasound. Some countries and even some states in a country, they have some difficulties to make that, and we can discuss the compromise of transabdominal measurement with the implications that it can have in terms of detection during our discussion time. But basically, the technique is very well described, and you have to follow that. The ideal scenario is the patient with an empty bladder. Maternal position is a semi-recumbent position with abducted legs. You are choosing a high-frequency vaginal probe to make the measurement. The probe is introduced in the anterior fornix in longitudinal X, and then you are identifying with gentle pressure the internal os and the external os of the cervix. The ideal scenario is to identify the inferior bladder border, the external os, the endocervical canal and mucosa, the internal os, and the limits of that. Minimal pressure, because pressure can modify and falsely elongate the cervix. Magnification is important. The cervix has to occupy 50 to 75% of the screen size. And then you are measuring a straight line, placing the calipers in the internal os and the external os of the cervix. The duration of the exam, the recommendation of the guidelines is at least 3 measurements. And normally take me around 3 minutes to do that. And some services, they are dynamic. And it's important to observe if there is dynamic changes during the examination, and you are using the shortest measurement for reporting. If there is additional findings, you are reporting that as such as funneling, the presence of sludge or so, but unfortunately, they are not very good predictors of a highest risk group when you are seeing that. Some pitfalls is to avoid a full bladder, to avoid extra pressure that you can modify the cervix. And of course, training is important, but it's a relatively easy technique. Some examples of cervix, and then you can see clearly that's a short cervix, in this case measuring 18 millimeters with the presence of sludge. Another cervix with sludge, the internal os is opening, funneling, and this patient has the stitch placed. Another example, that you can see the membrane going through the internal os, and it's a quite short cervix. And it's another case of a short cervix and the separation of the amniotic and the chorionic membrane. Some publications try to demonstrate that sludge and the separation of the membranes could be a factor of poorest prognosis, but this is still uncertain at this point in time. But what you can do if a patient is presenting at mid-pregnancy with a short cervix, restriction of physical activity, of baseline physical activity is not recommended. There's no evidence that this is going to decrease the rate of preterm birth. The first choice, as I mentioned before, is the prescription of vaginal progesterone, starting at the time of the detection of the short cervix and keeping that daily 200 milligrams up to 36 weeks of pregnancy. What you have to do with these patients after we detect a short cervix and starting progesterone is to do a follow-up of cervical length, depending on the length of the cervix, every 1 or 2 weeks, up to 24 weeks. If the cervix, even on progesterone, becomes shorter than 10 millimeters, then cervical cerclage has to be considered and to be offered and discussed with the woman. We know, unfortunately, that cervical pessary, the RB pessary, unfortunately doesn't work to prevent preterm birth in patients with short cervix. In a nutshell, just an overview of our guideline. What you do in asymptomatic single-dose pregnancy with no previous history of preterm birth is the measurement of the cervical length between 18 weeks to 24 at the same time of the morphology scan. And the preferable way is via transvaginal ultrasound. If the cervix is above 25 millimeters, routine antenatal care, no additional measurements is required. If the cervix is equal or below 25 millimeters, you are starting daily progesterone up to 36 weeks, and then we do cervical surveillance every 1 week or every 2 weeks up to 24 weeks. If the cervix becomes shorter than 10 millimeters, we have to consider cervical cerclage in this kind of cases. Australia probably is the first country in the world that just started this year, and I'm part of this initiative. That's a national program to reduce the incidence of preterm birth, and the goal is to reduce in 20% for the next few years. And basically, you're using the techniques that I described to you population-wise, and I'm sure that you're having some data in a couple of years to show you how effective is this kind of approach, thinking about in public health terms in a nationwide program. Thank you so much.
Thank you very much, Fabricio, for such a clear summary of an important part of this ISUOG guideline. Now we will move on to the second presentation by Dr. Conrado Coutinho. Dr. Conrado is a senior consultant in maternal fetal medicine in the Department of Gynecology and Obstetrics in Sao Paulo, Brazil. He's currently involved in various academic and associative activities in Brazil and internationally. He is member of the ISUOG's Educational Courses Task Force and part of the group of authors, as we said before, of these ISUOG practice guidelines on the role of ultrasound in the prediction of a spontaneous preterm birth. He will be presenting another important subjects from these guidelines. So please, you can continue, Conrado.
Hello, everyone. My name is Conrado Coutinho from Brazil, and I'm going to carry on with this presentation, presenting to you the summary of recommendations from the ISUOG guideline on the role of ultrasound on the prediction and prevention of preterm birth. I would like to thank all the co-authors of this important guideline for the brilliant team job. First population that I'm going to address now is patients asymptomatic for threatened preterm birth, but with singleton pregnancies and additional risk factors for spontaneous preterm birth on this current pregnancy. And every time we are talking about screening for spontaneous preterm birth, we should bear in mind that it's really important to obtain a really good clinical history and to try every time we see a patient for the first antenatal visit, we should always try to know if this patient had a previous preterm birth, if she has a multiple pregnancy, or if she has any one of these situations here that puts these patients at increased risk for preterm birth in a current pregnancy, mainly these two here. It's really important as well to perform a good clinical examination and to ask for complementary exams to try to find other risk factors such as infections. And although we have some tools like the cervicometer to try to predict the risk of preterm birth, nothing is better than the cervical length measurement using the transvaginal ultrasound scan as presented by Professor Fabricio. So for these patients with previous preterm birth, what we have to do is to measure cervical length starting from the beginning of the second trimester until 24 weeks of pregnancy, and to use progesterone or cervical cerclage depending on the cervical length, and depending also on one of the options that each service will need to adopt. And I will present both options starting from now. I'm not going to read the recommendations that we wrote on the guideline. I think it's easier to see on the flow charts. And this is the first option that we should opt, every service should opt for these specific patients. So if a patient has a previous preterm birth on the second trimester, so a miscarriage between 14 and 20 weeks, or a previous preterm birth between 20 and 27 weeks, we should start cervical length measurement from 14 weeks. And if the previous preterm birth was on the third trimester of pregnancy, we should start from the 16th week of pregnancy. In this flowchart, we would consider giving or prescribing vaginal progesterone for all patients with a previous preterm birth from 16 weeks until 36 weeks of pregnancy. And then we would start cervical length measurements, and if the cervical length measurement is above 30 millimeters, we would opt to see these patients every 2 weeks until 24 weeks of pregnancy, while the cervical length remains above 30 millimeters. If, in case patients have cervical lengths between 26 and 29 millimeters, we would opt to see these patients weekly instead of every 2 weeks until 24 weeks, while the cervical length remains within this range. But if the cervical length measures 25 millimeters or more or less, in these cases, for patients already using progesterone, we would opt to consider cervical cerclage. This is the option that we elected to use here in our service in Brazil, because it's easier to give progesterone that carries very low risk for patients and their fetuses and newborns. And it's difficult for us to offer ultrasound for a lot of patients. So we elected to use this flow chart here. But we have to acknowledge that nowadays, since the last years, publications are showing that progesterone does not work really well for patients with cervical length of more than 25 millimeters. So it wouldn't be probably necessary to use progesterone for patients with cervical lengths more than 25 millimeters, only for those with less than 25 millimeters. This was beautifully shown in this paper by Conde Agudelo and Roberto Romero. And the adaptation of the previous flow chart for this specific situation would be not to offer progesterone for all patients on the beginning of the second trimester, but to do the same kind of surveillance here and start progesterone only if the cervix goes below 25 millimeters. And for these patients, we should also keep on following the cervical length every 1 or 2 weeks after the start of progesterone, and in case the cervical length continues to shorten and approaches 10 millimeters, that we know that progesterone doesn't work too well for these patients, then we would offer cervical circulation. So I presented for you 2 flow charts. You should decide which one would be better for your specific service. Let's talk about the second populations that are patients with symptoms of threatened preterm labor. And these patients are about at least 15% of patients that look for consultations on maternities every day. However, although the number of patients with symptoms of threatened preterm labor is high on a daily basis, 25 to 45% of these patients, these symptoms will stop spontaneously. And only less than 10% of these patients will indeed have preterm births in the next 7 days, while the majority of them, almost 75% of them, can deliver a term. So we have to decide which patients we are going to admit and to use tocolysis as active management, taking also into consideration that if we delay tocolysis too much, if these patients have dilations of 3, 4, 5 centimeters or more, this increases the risk of failure of tocolysis. Once again, I'm not going to read the recommendations for the guideline for you, but it's important to say that this flow chart that I'm going to present is good for patients with gestational age between 22 and 34 weeks of pregnancy. So if these patients arrive at our maternities with cervical dilation of 3 or more centimeters, what we usually do is to opt for active management and consider hospital admission, tocolysis, and corticosteroids. This is what we have always done. But for the patients with cervical length below 3 centimeters, there is the doubt. Should we admit, should we not? And what we usually do is to reassess these patients after 1, 2 hours. And if the contractions improve and the cervical dilation is not changed, probably we can consider discharge with precautions. These patients can come back if the symptoms get worse. But if there is some kind of clinical progression for dilation on number of contractions, if the contractions are maintained, or just in case, in many cases this happens, if we are afraid that these patients are going to deliver, we usually consider for active management. And we have to admit that sometimes, retrospectively analyzing, we admitted too many patients. And this is why we should use ultrasound to help us decide if these patients should or not be admitted. And what we should do is to use ultrasound after digital examination, especially for those patients with cervical dilations below 3 centimeters, with lower risk of delivering in the next days. And if we measure the cervical length for these patients transvaginally, and the cervical length is more than 30 millimeters long, so these patients should, after reassessment in some hours, discharge could be considered, and they could come back if symptoms get worse. On the other hand, if the cervical length is short, and you have also to decide in your service one of these cutoffs, 15 or 20 millimeters, Americans usually use 20, and Europeans usually use 15 millimeters. These would be patients at higher risk of preterm birth in the next days, and we would consider active management for these patients. But there's another tool that could help us deciding, especially the cases between 15 to 20 and 29 millimeters, that are the point of care tests, such as fibronectin, PANG1, or PLGF-BP1. If you have one of these point of care tests in your service, you should collect a swab before doing the digital cervical examination. And if the flow chart continues until this point here, and you detect a cervical length by cervical ultrasound between 15, 20, and 29 millimeters, you should do the point of care test at this point. And If the test is positive, you should consider active management, more risk of delivery in the next 7 days, or if the test is negative, you should consider the patient more to decide here of the discharge with precautions. Last situation I'm going to talk to you is about patients with multiple pregnancies. So we have decided to follow up the recommendations of the 2016 ISUOG practice guidelines on the role of ultrasound in twin pregnancies. That said, that we should use the cervical length measurement by transvaginal ultrasound between 18 and 24 weeks of pregnancy, and the cutoff, the pragmatic cutoff, is similar to the singleton pregnancies and is 25 millimeters to define low and high risk of preterm delivery for these patients at increased risk of preterm delivery. And one thing that we learned recently is that using progesterone for unselected twin pregnancies to prevent preterm birth does not work. And we should not use progesterone only because the patient has a twin pregnancy. But probably it's beneficial to recommend the use of progesterone for twin pregnancies with cervical length below 25 millimeters. And this was shown by this trial published by Professor Nicolaides' group in 2021, the EVENTS trial, that has shown that even high doses of progesterone, 600 milligrams per day, given since the first trimester of pregnancy, do not prevent preterm birth in unselected twin pregnancies. But if we divide these patients with longer or shorter cervixes, and the cutoff here would be 30 millimeters, for the patients with shorter cervix, yes, there's a difference, and using progesterone can prolong the gestational age of delivery for these patients. Regarding cerclage, history indicated cerclage is not recommended and it's not beneficial for multiple pregnancies. On the other hand, patients with dilated cervixes elected for a physical exam indicated cerclage, used in combination with antibiotics and tocolytics. These might be considered for patients with dilated cervixes below 24 weeks of pregnancy. And unfortunately, cervical pessary, it does not seem to be beneficial for patients with singleton or multiple pregnancies, irrespective of cervical length measurement. Similarly, for patients with multiple pregnancies and with symptoms of threatened preterm birth, ultrasound or point-of-care tests do not seem to be beneficial to better predict preterm birth. So my take-home messages here would be, for the majority of pregnancies without risk factors for preterm birth, the use of progesterone is beneficial for patients with surfaces below 25 millimeters, and for those with surfaces approaching 10 millimeters, cerclage could be considered. For patients with history of a previous spontaneous preterm birth, you should do the cervical length surveillance and decide to start progesterone universally and use cerclage for those with cervical length below 25 millimeters, or start progesterone just for patients with cervical length below 25 millimeters and cerclage for those with cervical lengths approaching 10 millimeters. So every service will have to elect one of these strategies. And for patients with threatened preterm birth, if the cervical length is longer than 30 millimeters, these patients could probably go home safely and with precautions and coming back if symptoms get worse. But patients with shorter cervices, especially below 29 millimeters, you should use point-of-care tests to help you in this process, or opt for active management if for the patients with shorter cervices. Thank you very much, and here we end this presentation.
Thank you very much, Conrado, for this important summary. So we have now the main aspects to start the discussion about the screening and prevention on preterm birth. So I think we have here Fabricio. Unfortunately, Conrado will probably not be available for discussion. He had a last minute issue. So we will start answering the question. We have a couple of minutes to do this discussion. So Fabricio, there is one, the first question from the audience. Is there any reason why cervical length assessment is started from 18 weeks? Why not start from 11 or 14 weeks?
Thanks, Catalina. Conrado is at the airport. I think that he'll be able to connect us to join the discussion. It's an important question. This was responded by Leona and Arabi in the previous session, but if you didn't hear that, one is because the detection rate in the first trimester is not as good as in mid-pregnancy. Second, it's very hard to measure the cervix in the first trimester because the lower segment is not formed yet, and then we have the isthmus, and then the technique is not very reproducible as it is in the second trimester. And third, and Arabi mentioned that before, asymptomatic patients without previous history, actually the cervix starts to shortening around 18 to 20 weeks, not before that. In clinical practice, the only patients that I measure the cervix in the first trimester are the ones that had a very early preterm birth before, and then for me to define what's the best time in terms of surveillance, and eventually if a patient has the proper diagnosis of cervical insufficiency, for me to define the best time to put a stitch on.
Absolutely. So if we carry on with this gestational age matter, if we talk about the upper limit for screening, which is, we know, 24 weeks, and we know these 24 weeks are basically because of the survival limit for that was established for babies in high-income countries. Correct me if I'm wrong. Would it be reasonable in a low-middle income country setting to prolong this period of cervical length screening, or even think of preventive measures such as cerclage even further, ahead in pregnancy? What do you think?
I don't think so, Catalina. I think that's one of the reasons that we are stopping checking this cervical length at 24 is the one that you mentioned. That's the viability in the majority of the countries. I think that nowadays is not just in high-income countries, also in middle-income countries, the limit is 24. In high-income countries, certainly Australia is very well established, that's 23, and then we have the discussion that 22 is the limit of viability in some countries. Of course, the neonatologists are pushing that more and more to lower gestational age. But the other reasons that I think is because progesterone was not proven that if I'm starting progesterone later, if progesterone works. All the trials, they are done between 18 to 24 weeks. And the effectiveness and also the risk of putting a stitch over 24, I think that's very debatable. I don't think that we have evidence for that. I think that still in low and middle income countries, we can stick with the idea of 24 weeks. Thinking about transport, okay? Australia is a high income country, but we have transport issues like, big countries like Canada, and so it's very difficult for rural patients to arrive in my center, for example. Measurements over 24 could help eventually to think about inpatient transportation for a tertiary units, and eventually to start the steroids if someone has a very short cervix between, let's say, 24 to 28 weeks.
There, you raised another good question, and is what is the cutoff, or what would be the cervical length to think of antenatal steroids, because sometimes when you don't have any other measures to use and you follow up, you usually decide, or you could decide to give antenatal steroids based on cervical length. Am I correct? Do you do the same?
I changed my practice with the latest evidence about steroids, Catalina. I think that's in the past for patients with very short cervix or in labor, especially if they are contracting. I was starting the steroids early on based on cervical length. But now we know that steroids eventually can cause harm, especially if I'm starting steroids and someone's having at the end of the day a full-term delivery, and she had the exposition of steroids, including a high rate of HD during school time for these kids. My trigger for steroids now, I think that's is not as short as was before. I think that the patient really has to be in labor for me to start steroid, not based in cervical length.
Perfect. Absolutely agree. There is a new questions from the audience. Do you have any comments on prevention of preterm birth with in women with previous history of conization or any cervical surgery?
This kind of patients, they are high risk for preterm birth. In terms of lets or lip, depends of the number. One, I don't think that's a big risk factor. The risk ratio is about 1.1 or 1.2. I don't think that we need to do cervical surveillance. With two or more lets or lips, yes, we are not prescribing progesterone for these patients, but they need surveillance starting at 16 weeks and fortnightly up to 24 weeks. Conization normally is taking a larger portion of the cervix, and then we are doing cervical surveillance routinely for these patients, but just prescribing progesterone if the cervix becomes shorter than 25 millimeters.
Fantastic. Conrado is here. He joined us. Thank you, Conrado. We know you are in a very difficult place right now. Would you like to comment on this, Conrado?
No, thank you very much. Are you hearing me well, Catalina?
Perfectly, yes.
So thank you very much for the invitation. Sorry for this previously scheduled appointment. But I completely agree with Fabricio. And regarding lips and conizations, we addressed this in the guideline. And there is not much evidence regarding prediction of preterm birth on these patients. So our guidance in the guideline was to manage these patients in the same way as we do the other patients. So if there are no previous history of preterm birth, we should look at these cervixes between 18 and 24 weeks once only, and to prescribe progesterone if it's the case of a short cervix. And in cases where patients had previous preterm births, we start the surveillance from the beginning of the second trimester, and we manage according to the size of the cervix.
Perfect.
Catalina,
yes, yes.
if I may ask a question for you and Conrado.
Of course.
Relatively large number of patients, they are arriving at the hospital with the diagnosis of cervical insufficiency. But when you're checking the history, it's not really the case. You know that cervical insufficiency is quite rare. What are the criteria that you're using to make the diagnosis and to recommend the stitch as a first line of treatment?
You stole that question from me, Fabricio. That was the next one. Actually, yes, it is very difficult in our setting because I think there is an overuse of cerclage. For this patient, there is an overdiagnosis of cervical incompetence. We in our institution, we use use the woman needs to have 2 previous mid-trimester losses to think of cervical insufficiency, and you need to interrogate the patient and ask how the history of this preterm birth was, because many times it's very clear that the women start contractions or start from the beginning of the pregnancy with infections and things that you can actually start ruling out the real history of incompetence. So if you have a very clear history with no uterine activity, spontaneous mid-trimester losses, and more than 2, then those are the ones we put a stitch on. I don't know if you want to add something.
I completely agree.
Sorry, in Brazil is the same situation. Since 2014, the American College of Obstetrics and Gynecology, in their guidelines, they propose the history-indicated cerclage just with 1 previous loss. So this has been used more and more in the last decade. But publications have shown that if we do the cervical surveillance, even for these patients with previous history of suggestive of cervical insufficiency, we can avoid doing 60% of cerclages. So a good alternative is to start surveillance from the beginning of the 2nd trimester and manage the patients according to the cervical length. Although we know that in low and middle income countries, the availability of ultrasound scans might be a problem. And for these patients, you have to consider your setting to do a history indicated or to do ultrasound indicated cerclage.
Absolutely agree. I think we have 2 more minutes for one last question. So before we move on to the next session, in the guideline, you address the importance of the biochemical markers for symptomatic women to define, the management. We know, or at least in our country, the availability of biochemical markers is none. And I think that's the case for many LMICs. So what would be the alternatives? Should we advocate to get these markers, or should we just take or make decisions based on cervical length and clinic?
Yeah, I think, well, we have been doing what we have been doing the last century or more is to only rely on the digital vaginal examination to assess the uterine contractions, to see if we are going to admit or to use corticosteroids and so on. If we can include the transvaginal ultrasound, it will be of great help to avoid lots of unnecessary hospital admissions and medicalization. And a 3rd step would be the use of the point of care tests. In Brazil, we don't have access in the majority of our maternities, except for university institutions. So I think we have 2 things that we could include in our management. The first one would be transvaginal ultrasound. And if you have a transvaginal ultrasound scan in your department, it's going to be of great importance for these patients. And if you have the 3rd step would be the addition of the point of care markers. In Brazil, it's really difficult as well to get this kind of markers. I don't know what if you have in Australia, Fabricio.
Yeah, we have access here, but to be really honest, I rely more in the cervical length. And one thing to consider is to use a calculator such as QUIP, for example, that's giving you a specific risk, and then it's easier to counsel the patients. And I think that's the clinicians, they are a bit more confident when you have a specific cutoff, and it's easier for them to understand, and they'll be more comfortable to to discharge some patients that they really don't need to stay at the hospital.
Fantastic. Thank you very much, both of you, for this very important session on preterm birth, which, as we know, is the leading cause of perinatal mortality and morbidity. We will move on to the next session on screening and prevention of preeclampsia, another very important aspect as well, led by two experts, Professor Nicolaides, who needs no introduction, and Nuruddin Mohammed from Pakistan. Please go ahead. Thank you very much.